Hi, this is Dr. Kreider at Neuroregenix Edina, and we're going to do a quick webinar here on a common question that I get in the clinic, which is, what again do you do here, and how is it different than everything else that's going on? Because I'm hearing a lot of different things about this regenerative medicine, and I don't know where to get good information. So today we're going to go over what is regenerative medicine, what are the stem cells that we're commonly using for these treatments, what is interventional orthopedics, which is kind of the subspecialty that uses regenerative medicine to heal orthopedic injuries without surgeries. What is Regenix, which is the company that I work for, a physician group that's actually international and was the first group to use stem cells for orthopedics. How are stem cells in PRP produced, both here at Regenix and at outside facilities? Where are those cells injected? What are the important things to ask your doctor about? How are you going to get those cells to where they need to be? And what happens after that injection? Are you following the outcomes? How do you know what's going to happen after this procedure? And all of those things are kind of differentiating factors for how Regenix is a little bit unique compared to other clinics in this space. So looking at what is regenerative medicine, these are injections of the body's own healing cells to repair chronic injuries. So to do this, we remove your own healing cells from your body, either stem cells or platelet-rich plasma usually. We concentrate those cells and then re-inject them the same day. And so that's all FDA compliant use of your body's own healing cells to do what they're naturally doing in your body. But they just tend to not get where they need to be without us putting them there. So we're usually using stem cells from the bone marrow. Places will also use stem cells from adipose tissue or fat, although that's has less research behind it and has its own risks. So we'll talk a little more about that. The other main tool that we use is platelet-rich plasma, which comes from your own blood cells. The platelets are basically a bag of growth factors that stimulate repair. So they're not dividing into things like a stem cell would, but they are able to release growth factor to stimulate repair. Importantly, looking at what do stem cells do, they're able to differentiate either into themselves to self-replicate, or can differentiate into other tissue types, such as cartilage, tendon, ligament, all these things that we're trying to repair in the body. They're also able to stimulate neighboring cells by secreting growth factors that bring about other cells to do that repair process. Those signals can also modulate the inflammatory and pain response within a joint. And they're also able to donate their mitochondria to the cells that were already there. Mitochondria are the organelles inside of every cell that break down food into energy, and they wear out with time and aging. So by putting these stem cells, which have young, healthy mitochondria, they're actually able to tag those mitochondria and see that they move from one cell into the other, and are able to help those older cells to be more functional in the repair process. Importantly, on what are stem cells is also what are not stem cells. Unfortunately, a lot of providers are recommending, quote, stem cell treatments using something called amniotic or placental tissues, which are shelf-stable, dried, irradiated tissues that are byproducts of the birth process, which are then stored, shipped, reconstituted in the office, and injected and called a stem cell treatment. Unfortunately, when multiple groups have looked at what are the cells that are actually in that, there are no live, viable, dividing cells within that formulation. That's why it was able to be shelf-stable and injected into a different person. So just be aware if you're being recommended a stem cell treatment to ask where those stem cells are coming from. Are they your cells, or are they someone else's? Are they your fat or your bone marrow? So those all make a very big difference. The other question is, what is this field of interventional orthopedics, and how is that different than regenerative medicine? Interventional orthopedics uses precise injections of these biologic treatments into the areas of orthopedic degeneration to repair them. This is able to replace many of the elective orthopedic surgeries for a faster recovery and less downside. Importantly, this relies on the ability to inject any joint, tendon, ligament, or bone using either ultrasound or fluoroscopy. So using advanced guidance to get these cells not just into the joint generally, but into each of these substructures that can become degenerated and cause increased wear and tear and increased pain. And so on the spectrum of simple injections to surgery, most physicians that do musculoskeletal injections are doing more of the simple in the joint injections, like a steroid shot would be done in your shoulder joint, in your hip joint, in your knee joint. Interventional orthopedics is unique in that physicians that specialize in this have done extra training in order to be able to use image guidance, either the ultrasound or the fluoroscopy, to specifically target each of these substructures, which can by themselves cause pain and dysfunction of that joint. So we're talking about ligaments, tendons, meniscus, labrum, the nerves that modulate the muscles. This is that's why interventional orthopedics is a subspecialty, rather than just saying regenerative medicine is interchangeable with steroids. You just inject them in the joint. No, we're really targeting all of these structures around the joint to repair the entire joint and all the parts of it. So Regenexx actually started with the Centeno Schultz Clinic out in Colorado when Dr. Centeno and Dr. Schultz did the first study in a human study using the patient's own bone marrow stem cells injected into the joint for orthopedic repair. And that was done in 2006. And above you see the before picture of the patient's hip where he had really broken down joint line in the hip. And this is several months later where he's now regrown a very nice joint surface. And the patient also had an excellent pain response. And so the success of that case study led Dr. Centeno and Schultz to then found Regenexx with the purpose of continuing this research, advancing this new field, as well as expanding it across the country with new physicians who would come to their clinic and learn their techniques to bring about these high-level treatments to the rest of the country. And so this is a chart that Dr. Centeno made showing all of the stem cell studies for orthopedics that have been done since that time. There's actually been new studies in 2019, including a large Regenexx study on stem cells for knee arthritis. But with this, you'll see that circles are bone marrow stem cells and squares are adipose stem cells. And so you'll see that most of the studies have been bone marrow and the adipose have been more recent and a fewer number of patients. The yellow circles are actually Regenexx studies. Like I said, there would be one more in 2019 and more to come. But importantly, 44% of all the patients involved in all of these studies were actually in Regenexx studies. So there's relatively few large studies in this field, and most of those large studies are done at Regenexx clinics using Regenexx protocols. And so to really compare apples to apples is difficult when clinics are doing different protocols with different inject dates. And so they took that research study on the hip and really built a large university-style lab within their private practice, which is very unique to have a lab such as this outside of a university setting. So on the left, you have Dr. Nevin Steinmetz, who's the PhD leading the Regenexx research division. And this is a little tour of their labs. They have cell sorters that can separate to tell how many stem cells you've gotten, look PCR to look and see what genes those cells are producing. Are the cartilage cells secreting collagen or not? Are they active? Sterile hoods to separate and isolate those cells, incubators to grow them. Obviously, we're not in the United States growing and re-injecting those cells back into people, but it is useful for growing them to see how different inject dates influence the cell division and cell viability. And you know, this is very important because most physicians learn about new developments and new products from the sales reps that are selling those products, and it's very hard to really verify if they're selecting, case studies that are showing you what they want to see. So at Regenexx, they have this lab on site where any new product they can actually test against stem cell assays, as against cartilage, grown in a dish, and see, does it actually pass muster? Are you actually getting improved cell yields, improved cell viability? And then they don't roll those products out to the rest of the network until they've passed the test in the lab. So this is an example of platelet lysate and how that's changed over the years. Platelet lysate is where we take platelet-rich plasma and lyse the cells to make just a serum of growth factor. So ideally, you would have high levels of growth factor, which is these graphs on the right, and low levels of whole platelets after lysing them. A first-generation lysate would be what you would get from just freezing it overnight. And this is what any clinic that's using platelet lysate would typically be able to make. With that, you still have a high number of whole platelets and a relatively low number of free growth factors. And then over the time, REGENXBIO has fine-tuned that protocol. They're now on the 4th generation. But even by the 3rd generation, they had very low levels of whole platelets left at the end of that lysing process and very high levels of free growth factors. And they've continued to modify their protocols for the other injectates that we are able to do as well. So, like I said, they figured out how to process adipose stem cells in an FDA-compliant way. If the research ultimately proves that adipose is better than bone marrow, we'll be able to do that with REGENXBIO. They're able to make alpha-2 macroglobulin from your own blood, which is a molecule that blocks the breakdown of cartilage. And really, all of these are ongoing processes that are rolled out to our lab techs on site as they come out with improved methods at the REGENXBIO laboratory. They also use that lab to evaluate other aspects of the process. So most importantly is, how are you getting those stem cells? Like I said, bone marrow is the most researched and least invasive site of stem cells. It's nice because you can just, a poke into the bone and withdraw marrow is relatively non-invasive compared to a liposuction procedure where they have to insert this wand under your skin and wave it around to break up fat tissue, which also breaks up nerves and blood vessels and has a higher rate of complications. So because of that, we're continuing to use bone marrow, but even bone marrow harvests are different site to site, and REGENXBIO has researched the best way to do that and has come upon a multi-site low volume draw, which takes longer to do and is a little more difficult, but you do get ultimately better yields, which will give you the best product and the best chance of having a good outcome. So we're really doing multiple sites along the back of this PSIS bone at multiple depths in order to get the most cells possible. And as new companies come out with new devices and new claims of getting more cells or more viable cells, REGENXBIO really does test that in their lab and only rolls out the ones that truly deliver a better product to you. A lot of this comes down to how do we process your cells in order to give you the best possible outcome. And what REGENXBIO uses is called a flexible lab platform, which means that we're making it by hand in a sterile hood with a lab technician who's been specifically trained in Colorado how to do this and updated constantly as REGENXBIO comes out with new protocols. On the other hand, everyone that's not REGENXBIO is using an automated bedside centrifuge, which is a machine that does it automatically, and it gives a very cookie cutter product, and you're locked into that product once you buy the machine. So whereas we're able to constantly update our process, the machine is going to give you what it gives you. This is a little more involved for us, but what that gives us is a more pure product. So the machine is not able to separate off the red blood cells and white blood cells very effectively. If you are going to really dial it in to try to take out all the red cells, you're going to start losing platelets as well. Versus when we do it by hand, we're actually able to very carefully pipette off just the platelets and get all of the platelets and leave behind all of the red blood cells and white blood cells, which cause a lot of inflammation and pain. And the same thing goes for the stem cells, where we're able to really keep cells that the machine would not be able to siphon off effectively. And so we're able to get stem cell concentrations that are 20 to 30% higher than what the machines are able to give. The machine is only able to gives a cookie cutter product each time, 6 milliliters of 6 times the body's natural concentration with regards to PRP, and a similar idea for stem cell. Versus when we were able to making it by hand, we can customize how concentrated we want those to be. So we can go all the way up to 20 times concentration for PRP, which is very useful in, example, a very small joint where you want to get as many cells as possible in without having to put a ton of volume in. You need to concentrate those cells a lot because it is dose dependent. If you're only putting in 1 milliliter of 6 times, you're having 1/3 the number of cells as if you could have done 18 times concentrate in that joint. And we also would sometimes use a higher concentrations in older folks or in other cases. The machine also gives a set volume every time of around 6 milliliters, which really limits the number of areas that you're able to treat. So when I showed that interventional orthopedics, targets of all the things that we're able to inject, if you have only 6 milliliters, you will only have enough to inject in the joint, and everything else you might inject with prolotherapy or simply ignore. Versus making it by hand, we can just draw more blood, and we'll draw enough to make what we need in order to treat all the areas that we want to treat. And so it's a very customizable procedure because of the flexible lab platform. So questions that you want to ask your doctor when coming up with a plan for regenerative treatment is, where are you planning to inject these cells? Are we talking about, just into the joint, or are we talking about all of these ligaments and tendons that contribute to joint stability and contribute to joint pain? So you've got ones that are on the outside of the joint. You also have ones that are on the inside of the joint with your ACL and PCL. And these, you really do need image guidance in order to accurately treat. You can't just put them into the joint generally and expect them to make their way into these ligaments or tears. Furthermore, for these ones that are deep inside the joint, you really need fluoroscopy, which is a live x-ray machine, in order to see through the bone and to get the needle into this is in its own sheath. And so an injection into the knee joint is not going to make it into the ACL. And so you really, if you're going to target some of these structures that are contributing to a loose and painful joint, then you really need to have the volume in order to have enough to treat all these areas, and you need to have the image guidance in order to actually get it into those areas. And furthermore, not just focusing on the knee joint, but the things above and below that influence the knee joint and cause it to become painful in the first place. So, thinking about hip and foot in the case of knee, and looking at abnormal movements there that could be due to muscle, nerve, or tendon issues. And then even looking higher up to the spine. And so, pinched nerve in the back can influence the hip muscles, which influence the knee movement. And so really focusing, not just being a knee specialist or a hip specialist or a back specialist, but being able to do all of those areas is very important and pretty rare in the field of sports medicine or interventional spine to have any amount of crossover. But with Regenexx, we feel it's very important to be able to do both. So that requires the knowledge of how to use both of these imaging modalities. On the left, you have fluoroscopy, which is an x-ray machine that allows you to do, for instance, spinal injections and see that the dye is tracking along that spinal nerve. Also, like I said, necessary to do bone injections for like osteonecrosis, or ACL injections deep inside the knee, disc injections, things like that. You would need fluoroscopy and need to be a spinal specialist. But you also want your doctor to be a sports medicine specialist and able to use ultrasound guidance and find these tears in the tendon, because if you inject it blindly, chances are you're going to end up in the muscle out here or anywhere else. So you really need to see the needle going into the tear in order to get them where they need to be. Unfortunately, some doctors don't know how to do either of these and will just do intravenous injections, which almost entirely end up in your lungs. So if you look at where how the blood flows, blood in your veins goes to your heart, which then goes to the lungs to be oxygenated. And the lungs are like a sponge that soaks up everything that comes through. And so 95% of those cells injected into the vein end up getting caught in the lungs, and only 5% of them make it through the lungs and disperse to the whole body. And of those, even fewer make it to the knee. And of those, even fewer make it to your meniscus, for instance, because a lot of these areas that are degenerating, the reason they didn't heal is because they don't get good blood flow. And so we really need to remove those cells and put them right where they're needed, because they're not able to find their way there on their own. In the case of like stem cells, like I said, they need to get into the tear in order to know to become tendon. And in case of cartilage, they really need to be dripped onto that cartilage surface because they're very sticky and they become what they're next to. So even just injecting them into the joint like a steroid shot would be ineffective. You really need to get it onto the area where the cartilage is bad using image guidance. Another thing to think about is, what are you injecting them with? And so a lot of the things that are commonly injected into joints, Regenexx has found, are actually toxic to cartilage cells and stem cells. And so we're very aware of that whenever doing any joint injections of, what dye we're using. Some of the dyes are toxic to those stem cells, what kind of numbing we're using. The lidocaine is actually toxic to stem cells and cartilage cells. And then what other injections have you had recently? So high dose steroid injections are toxic to the cartilage and also block your healing response. And so you don't want to follow that up either before or after with regenerative medicine without letting that wash out first. So really having an awareness of what else is going on and where those cells are going and what they're going with. And finally, what happens after you've had your procedure? How do we know whether you're going to have a good outcome or not? Like I said, there are not very many large randomized trials, and the large studies that do exist are mostly using Regenxbio protocols and Regenxbio super concentrated platelets and same-day stem cells, which are different than what the bedside machines are giving. So we'd really be comparing apples to oranges to use a lot of the larger studies that are out there. So in order to compare our apples to our apples, we've created this Regenxbio outcome registry back in 2006, and every patient across the country that has a Regenxbio procedure is entered into this database. This is then published online for patients, for everybody to see the outcomes, long-term follow-up on how people do after these procedures. So it helps you maybe have some confidence that people are actually getting better from these things. It also helps us to recognize who does well, who doesn't do well, who's a good candidate, and what makes someone a good candidate by looking back at our procedures and seeing how they did. For instance, we found that age is a factor in hip arthritis, but not knee arthritis. So if someone is elderly with a severe hip, we might recommend hip replacement versus an elderly person with a severe knee. We'd say we still see very good outcomes doing stem cells. Similar with severity on imaging, we've seen that that's correlated for hips, but not for knees. So having bone on bone in the knee does not make you a bad candidate for our treatment. I can't say whether it would make you a bad candidate for someone else's treatment, and neither can they because they don't actually have outcome data. We've correlated how many cells we actually need to have in a joint in order to get a good outcome. We want at least 400 million cells, and that requires that we have a cell counter, which is a pretty expensive tool that most clinics don't have, but because we're researching it, we count this how many cells we get each time, and then we tailor our treatment so that we're not spreading those cells too thin, that you're getting at least that minimum number in any joint that we're focusing on. And so by being a part of this Regenxbio outcome registry, you're contributing to the medical understanding of this field of who does well and showing that this works, which also helps insurers who are thinking about covering this procedure and will ultimately help make this procedure more available to the masses. So here's a chart from the Regenxbio outcome registry. This is regarding the knee, but it's similar for most joints, where you're seeing that at the end of 4 years, almost 80% of people are getting at least 50% improvement. So if 50% improvement is a success, almost 80% of people are getting that. Only 24% of people are getting less than 50% relief. And that is, continuing to rise and is sustained at 4-year follow-up. It does not fall off at 4 years. It's just that the number of patient follow-ups starts to drop out so that the data becomes less meaningful as you go further out. But we've been following this since 2006 and seeing a lasting improvement that does not wear off. When you look at the average improvement of all patients, it follows a similar curve where 3 months out, people feel on average 46% improved. And then 1 year, 2 year, 3 years, by 4 years, people feel on average 63% improved. And quite a few patients involved in this. So hopefully that was helpful in clearing up some of the questions of what are all of these stem cell treatments and how are they different depending on where you go. Hopefully it's helped showed some of the quality and intentionality that's been put into the Regenxbio product and the research behind it. And hopefully it's convinced you that we might be able to help you with some of your injuries. So go ahead and schedule an appointment if you think we might be able to help. If you're not sure and you just want to learn a little more about all this, you can certainly call and speak with our regenerative specialist for no charge. You can answer general questions, or you can certainly do some more of your own research. I highly recommend regenxedina.com as a good resource that has, if you click on results tab up at the top, it has, for instance, before and after MRIs, before and after our Regenxbio treatments, as well as the outcome registry results. And so you can see how people have done over the last 13 years. It has an excellent blog by Dr. Centeno for the last 13 years where he comments on studies that come out as well as links to all of the research that we've published and other studies in the field, safety trials, things like that. Good luck with your research, and I hope I've been helpful. I look forward to meeting you. Thanks.